Like she said, so my name's Dr. George Adesina. I'm a general cardiologist at Kelsey-Seybold, entering I guess I just made a year and a half actually, and this is my second time here. So I just want to give a big thank you to UHG as well as the Women's Fund for even having me. One of my passions in my practice is patient education as well as prevention cardiology. So I'm very excited to be here to talk to you guys, and I hope I give you some good information to help you guys with your cardiac health as well. So, addition to February being Black History Month, it's actually also Women's Heart Health Month as well too. So this time we're going to dive in a little bit deeper and really talk about the differences between men and women and how women are usually at a higher risk for cardiac events as well. I definitely want this to be interactive, so we'll leave some time for question and answers. It sounds like you guys are going to have some questions prepared, so try not to stump me too much, hopefully. Okay, so let's go ahead and get started. So anytime we're talking about cardiovascular health, it's really important to understand what are your risks, okay? So we can split this up into two different categories. One is, things that we can't control and things that we can control. So things that we can't control, these are the kind of the cards that you're dealt with when you're born. So you can blame your parents for stuff like this. So this is your age, your gender, your family history, your race, also your genetic history as well too, which is a big important topic. Things you can control. These are things like your blood pressure, your cholesterol, diabetes, whether you smoke or not, as well as your overall body health as well too. Body weight. So when you go to the doctor, these are the things that we usually nag our patients about the most because the presence or absence of those factors really affect your risk of developing cardiac issues later on in the future. So when we break this down a little bit more into background as well too, there are disparities when we break this down for race. So looking at hypertension here on the left-hand side, you can see that African Americans definitely have a higher risk of having hypertension. And so all of this information, this is from a survey that was done by the National, I believe, Nutrition and Health examination back in 2015 or 16. And so these are all patients who are above the age of 20 or so. So if you look, African Americans are definitely at a higher risk just to have hypertension at baseline. Looking at obesity, this trend continues also for here. So if you see here, African Americans had 47.2. So African Americans are having a higher incidence of having obesity in addition to Hispanic patients as well. When we break this down even further for diabetes, again, there seems to be definitely a trend between African Americans and Hispanic patients. This difference isn't as much as obesity and hypertension, but you can definitely see that there's a clear path. It seems to be more common. And then looking at cholesterol, this was the only category that didn't really see that big of a difference. So this is looking at your overall total cholesterol levels. So it's about the same across the board, but actually in this case, white Americans actually had a little bit higher chances of having a higher total cholesterol. Now, what are the differences between men and women? This one things gets quite a bit different. So, the saying, men are from Mars, women are from Venus. This also goes for your heart as well, too. So if you look at the human heart, a man's heart is going to be quite a bit different from a female's heart just at baseline. So looking at differences and such. So a woman's heart is actually pretty much smaller than a man's heart. And this goes for the chambers of the heart as well, too. So if you see this little cartoon up here, you have two top chambers on the top and then two bottom chambers. So if you compare versus a man versus a female, women's hearts in a total sense is going to be smaller, but the chamber sizes themselves are also smaller as well. And even this tissue, which we call our septums, that separate these chambers, they're actually quite a bit thinner as well. The interesting thing is the female and men's heart actually respond differently to stress as well too. So if you look at a female's heart during a stressful episode, their pulse actually increases and they start to eject or pump more blood to their organs and such. Versus with men, when they're stressed out, instead of increasing their pulse, their blood pressure actually goes up. So those little small differences we think might account how women present differently when it comes to cardiovascular health. But the process itself of developing coronary artery disease is the same in men and in women. So if you look on the right here, these are pictures of coronary arteries. So your coronary arteries are the vessels that actually deliver blood flow to your heart muscle, which is called the myocardium. So imagine somebody takes out your heart vessels, they put them on a chopping board, and they slice them like a slices of a cucumber or so. That's what you're looking at here. So on the top here, this is what a normal coronary artery should look like. So you see, you have the vessel muscle, but the actual lumen here is completely clean. So it's almost like you're looking down the tube of a straw. That's what we want it to look like, okay? Now, when you have extra fats that are circulating in the bloodstream, you start to have deposits in these coronary arteries. And that's what's going on here. So you can see a clear difference. You see all that gunk and plaque that's forming here. And now the lumen of the artery is already starting to decrease. So with time, this can get worse and worse. Oh, excuse me. This can get worse and worse and cause an obstruction in this artery. Now, the way the body kind of works is if there's anything foreign going on, it likes to wall it off and tries to protect itself. So in this little plaque formation, usually an area of connective tissue forms here, and it forms a fibrous cap. And that kind of helps stabilize this plaque in the artery. When someone has a heart attack, what usually happens is this plaque becomes unstable. It bursts out into this lumen here, and your body responds to try to wall it off by forming a clot. So that's this picture down here. So you have a mixture of both of plaque, and then of course the blood clot here. This is what causes a heart attack. So you can see if you go from here to here to here, once you get down to this bottom chamber here, there is no blood flow getting to that artery, and that's what causes a heart attack. So even with the differences of hearts, or in general with the men and female, the actual process for coronary artery disease is the exact same. But there are definitely risk factors that women have that men don't. Okay, so one, having endometriosis or polycystic ovarian disease, or even having high blood pressure that develops during pregnancy automatically increases a woman's chances of having a cardiac event later on in life. For some reason as well, too, heart attacks are usually harder to diagnose in women. A lot of times they present quite a bit different from men, and we're going to talk about that more in a little detail coming up. The things that are kind of unfortunate is that women also tend to have more complications when they have a heart attack as well. So if you take a man and a female of the same exact, pre-risk factors as well as age, if they both enter the hospital, the woman's going to be more likely to die while she's in the hospital. She tends to stay in the hospital a little bit longer, so her hospital stay will be more complicated. And then even in that first 12-year period, they're at an increased risk of having a secondary heart attack as well. So there is a clear discrepancy between men and female in this area. And then in regards to presentation, women tend to be quite a bit older when they have their first heart attack. So the average age with men is usually in their 50s or 60s versus women are usually later in their 60s or 70s. One of the theories for this, if we're thinking, is menopause. So studies have shown that estrogen has a lot of effects on different tissues and cells in your body, and the heart is one of the ones that gets hit hard by this. So remember that picture we were showing before? This is what you want your artery to look like. Estrogen actually helps with this. It helps decrease the chances of plaque forming and kind of sticking to the artery wall like this. It can also actually decrease the amount of cholesterol you have as well too. So there's a protective factor for sure. So with menopause, at a certain age, women tend to stop producing estrogen and progesterone. It's that estrogen that's really affecting this. So their risk of having a cardiac event goes up tremendously postmenopausal. The other effect is, and if you talk to women who have gone through menopause, they tend to have palpitations as well. For some reason, when that estrogen level drops in the bloodstream, it causes the heart to start beating faster and sometimes harder. So they have that sensation of feeling palpitations, and that overstimulation of the heart causes the heart muscle to actually be overworked in time. So just this hormonal shift on its own already is going to increase a woman's risk. So now that we know what puts you at risk, let's talk about the warning signs and things you should be looking out for. So from a symptom standpoint, if you compare a male and a female, there are very big differences. So during my first cardiology rotation in medical school, on day one, they teach you what's the kind of classic heart attack sign. And they always tell you it's that substernal chest pain right in the middle, very severe, weak enough for someone or strong enough to make somebody weak in the knees. Surprisingly, that's kind of more typical for men. So I always kind of joke about this because the stereotype is that men are kind of the tough, rough and tough that can handle pain, and women are supposed to be the quote unquote dramatic ones. But when it comes to heart attacks, it's actually pretty flipped. It's the men that present pretty dramatic, having severe pain, and it's the women that have more faint or kind of more subtle symptoms. So a lot of the times women will have these symptoms, they'll try to work through it, continue to go on in their daily lives, and they're having an actual cardiac event throughout the whole entire time. So for men, usually it's chest pain right in the middle that goes down to their left arm, sometimes their jaw. And again, it's very, very, very severe. With women, it's the complete opposite. So they do also get the chest pain in the middle, but usually it radiates to their back. And the most common location is being in the middle of their shoulder blades. I've actually had some patients not even have chest pain and just have that back pain alone. Other symptoms that can be associated with it is having some slight nausea and vomiting. Very, very commonly, they'll say that you'll automatically get a severe sense of fatigue. And the number one thing that it gets mistaken for is indigestion. So I cannot tell you how many times I've had female patients come in and be like, you know what, doc, I'm having horrible, horrible heartburn, but it's different from my usual heartburn. It's not going away with antacids. It's not getting better with Pepto-Bismol. It's not happening when it's associated with spicy foods or meals at all. Anytime I hear that, your suspicion or your red flag for a cardiac event has to go up. So that's the number one thing we usually get it mistaken for. So anytime your husband, boyfriend, anybody says that women are dramatic, remind them of this, because it's the guys that are coming in dramatically. So the other important thing to remember too is that we usually put a lot of emphasis on straight up coronary artery disease, but heart disease, especially in women, comes in many different forms. So I kind of want to talk about some of the more rare things that we really usually don't really talk about, okay? So one is trigeminal angina. So angina is just a medical or a scientific name for chest pain. What happens in this syndrome is that the coronary arteries, instead of them having a true heart blockage of plaque, the arteries tend to spasm. So imagine if you have a garden hose and you press really hard on that hose, you're going to obstruct water from coming out that hose, right? Same thing with your artery. If those arteries are clamped down or obstructed briefly, they're going to decrease the amount of blood flow to the myocardium or the heart muscle. And this can actually mimic a heart attack. So I've had young women as young as 35 have this. They go to the hospital. When you check these patients, when you check their bloodstream, they have the cardiac enzymes that look similar to a heart attack. If you get an EKG, their EKG looks like they're having a heart attack as well. But then we actually go in and do an angiogram. Their arteries are completely clean, but we notice that they have these multiple areas of these arteries clamping down. We're not really sure what causes this from a genetic standpoint, but things that can make this worse is being exposed to cold weather. Stress can do this. And any stimulant or medications that causes your arteries to clamp down, like cocaine and stimulants like that, can also calm this as well too. The good news is this is almost 100% reversible. So we usually just give patients like nitroglycerin or any type of medications that help the arteries dilate, and the chest pain goes away, and it's 100% preventable. But I've seen multiple cases of young women having this, so that's really important. And surprisingly, there is a possible kind of hypothesis that there might be a hormonal shift that happens either late at night when women are sleeping or early in the morning, because they tend to present in the ER in the middle of the night or first thing in the morning. So that's something that we're still kind of trying to figure out what the actual cause is. But this is something I think that doesn't get talked about a lot, but it's something that's very common. Something else that we don't talk about as well is peripartum cardiomyopathy. So this is a specialized form of heart failure that happens in women mainly in the last weeks of their third trimester and up to 5 to 6 months after the baby is born. And so with this, they will develop heart failure almost without any cause. After we do our workup, there's no kind of explainable reason for this heart failure, but they tend to get it during this period. About 10 to 15% of affected women we think have a genetic kind of predisposition, but we're not exactly sure what causes this. Women who are usually at risk are women who are having children over the age of 35. Women who are African American, if they've had multiple children in the past, and especially women who are carrying more than one child. So twins, triplets, quadruplets, they are at a higher risk as well too. Symptoms that you usually get for this is like fatigue, your heart racing, your blood pressure decreasing, swollen legs as well, and very, very difficulty breathing. Now, the problem with this, and I'm sure every woman that's been pregnant here knows, those are usually common symptoms of your third trimester. So as the baby gets bigger, you usually are going to have some swelling. You might have some shortness of breath, but these symptoms are usually very, very drastic and very severe. The only way for us as cardiologists to diagnose this is to get an echocardiogram or an ultrasound of the heart, and it'll show that their pumping function is decreased. The good news is a lot of this can be reversible as well with medication as well. But any woman who's had this with one pregnancy is going to be at an increased risk of having this for her next pregnancy as well. Okay. So now that we kind of know what to look out for, we know some of the kind of different forms, what are the things that we can do to kind of maintain our heart health, okay? One is knowing your numbers. So I kind of equivalent this to, it's almost like you're taking your car for a maintenance. When you go into the dealership, they give you a checklist of how all the systems of your car is doing. This is the same thing that should be going on with your doctor. So we always recommend everybody getting a physical once a year, but especially men and women over the age of 40, that's when it's really, really time to make sure we're doing this at least once a year. You want to make sure your health professional is checking your cholesterol. So just looking at kind of overall goals, we usually want your total cholesterol to be less than 200, your bad cholesterol to be less than 100. And in patients who are at a higher risk, like those who have heart disease, have had strokes or diabetes, we actually get a little more aggressive and want that bad cholesterol to be closer to 70 or so. So before, like when I was in medical school and training, we actually used to just purely treat these levels based off of the levels. But we actually found that if you only look at that and don't look at the big picture, you're actually under-treating a lot of patients, women in particular. So there's a risk score that we can calculate every time you get your cholesterol checked, and it's called the 10-year ASCVD. And what this does is it takes into account your gender, your race, whether you're a smoker, whether you have diabetes or high blood pressure, and it spits out a number. Anyone who has a number of 7.5%, that means you have a 7.5% chance of having a cardiac event in the next 10 years. No matter how pretty your cholesterol panel is, you automatically should be on cholesterol medication. Even for a high-risk patient, so those, again, they've had a stroke, they've had a stent, they have diabetes, we still calculate this score as well too, but it kind of gives us an idea of which types of medications they should be on and the dosage as well. So anytime, especially if you're above 40, you want to get this checked every year and really encourage your healthcare provider to be making sure they're calculating this. I'm really anal when it comes to this, so I do this in front of the patient because I think it really helps you understand your risk and things that you can do to decrease it as well. Blood pressure. Now, ideally, if you look, the textbook blood pressure of what we want you to kind of be around is 120/80. The guidelines change almost every 1 to 2 years. So once you start getting that top number gets in the 130s, you're considered pre-hypertensive. But anyone above 140/90, that is bona fide hypertension. So hypertension is so common, as we saw in those slides before. The problem with high blood pressure is people walk around with an elevated blood pressure and they feel perfectly fine. So I think I had a similar story last time I was here last year. So last week, I had a patient who came in, her blood pressure was 220/120, and she looked perfectly fine. So when my nurse checked her blood pressure, of course, as a provider, I freaked out, making sure she wasn't having a stroke or a heart attack. I walked in the room, she was sitting there on her phone playing Candy Crush with no problems at all. What usually happens is when you have high blood pressure, especially over a long period of time, your body gets so used to dealing with that high blood pressure that becomes your normal, so you don't feel bad from it. And that's why hypertension or elevated blood pressures are considered the silent killer, especially in our minority patients, especially our African Americans. High blood pressure is one of the major reasons why they end up being on dialysis and having kidney failure. So it's really important that you're going to the doctor and getting your blood pressure checked once a year. If not, you doing it at home yourself as well too. Fasting blood sugar. So we check a fasting blood sugar. Ideally, we want that less than 100. And we do this because we want to figure out if our patients are either pre-diabetic or diabetic. Those who have diabetes will know we get very, very worried with our diabetic patients. It is a treatable condition, but diabetes alone increases your risk of having cardiac events. So when men who have diabetes are 2 to 3 times, their fold, I can't even talk today, excuse me. Sorry, y'all, I was on call last night, so that's probably why I'm talking like this. But for men who have diabetes, they have a 2 to 3-fold increase of having cardiac events. Women, it's even more drastic. So they have a 3 to 7 time increase fold of having cardiac events. So it's really, really important. If you have diabetes, it's really, really important to get your blood sugars under good control. Now, body weight. So this is something we all struggle with, and it is a sensitive topic when we're trying to talk to our patients. But controlling our body weight is going to really help, not just in our cardiovascular event, but helping your body function just at its optimum. So there's a couple of ways that we can figure out if a patient is kind of at their goal or ideal body weight. There's one metric that we use, which is called BMI, which is body mass index. And what that does is we can actually calculate and tell you for your actual height where your weight kind of should lie. A healthy BMI is usually between 18 and 24. Once you get to 25, that's considered overweight, and anything above 30 is considered obese. And so I think obesity is a sensitive word for us to use. And I think most people, when they think about obesity, they think of that, 600-pound patient that's, can't leave their house and bedbound. But in fact, if you look, the average Texas-sized person actually qualifies to be clinically obese. And when you're in that range, your risk for having cardiac events, strokes, all that stuff increases. Okay. Now, BMI is not necessarily a perfect science, especially for women and people who are curvy as well. So another way to kind of get a better idea of how your ideal body weight is to use the hip to waist ratio. So not all fat is created equal. Mainly the abdominal or belly fat, that's what's going to increase your risk of having cardiac events. So if you measure the circumference of your waist and then measure your circumference of your hips, you want your hip circumference to be larger than your belly, essentially. So like, having like the gut, the dad bod, all of that stuff increases your risk. So when you do this for men, you want that ratio to be less than 0.9, and women, you want it to be less than 0.85. Okay. Now, it's really important as well. Mental health is a big part of cardiovascular health. And I know this is a cardiology talk, and this might seem out of left field, but we are actually seeing a huge connection between your brain and your heart. So they've actually done studies on this. People who are in the hospital and they have heart attacks, up to 40% of them will have some type of depression or anxiety in the next months leading after that. But I am actually a firm believer that stress and anxiety, if it's uncontrolled, even if you don't have heart disease, has a strong hold over your heart. So my wife and I were talking about this yesterday. So one of the first weeks when I was an intern, I had a very, very obese patient. He was getting up to use the bathroom and he collapsed in the door frame of the bathroom. And because he was so large, we couldn't get him out of the door frame. So mind you, I've been a doctor probably for like 2 whole weeks when this happened. So I had to climb over him, and I was halfway in the bathroom, halfway in the room doing chest compressions. And this is a little gory, but I think it's important to keep this into context. So he had just had chest surgery. So he had an open wound on his chest. So with every compression I'm doing, he's bleeding and I'm getting blood and everything. It was straight out of Grey's Anatomy. That's how severe this was. So unfortunately, the patient didn't make it. And my wife, girlfriend at the time, just happened to call me. And I was telling her the story. And she was like, "Are you okay?" And I was like, "Yeah, why? I'm going to get lunch. I'm okay." And she's like, "Do you hear what you're saying? Like, you just went through something pretty traumatic. Like, are you okay?" And I was like, "Yeah, it's a normal Tuesday. Like, I'm an intern. This stuff is supposed to happen." And so I was hanging up the phone and I started realizing my hands were shaking because of all the adrenaline. So that happens with a lot of people. We operate at such a very high stress level. We don't even realize how much underlying anxiety and stress we're dealing with. And this is in particular, I think, really affects women because, of course, traditionally women are the caregivers. So they're juggling their jobs, they're juggling children, juggling their spouse, other family members. And a lot of the times, they're putting themselves on the back burner and taking care of everything else. So a lot of times I really feel like we're operating at such a high stress level, trying to multitask and just keep up with the demands of life. If that stuff doesn't get taken care of, that can definitely cause some issues from a heart standpoint. So you'd be surprised. I would say probably 60% of patients that I see under the age of 35, they're coming in complaining of cardiac-like symptoms, but when we do the workup, it's usually anxiety or panic attacks. So I want to briefly talk about this as well too. The problem is, a lot of the symptoms between panic attacks and heart attacks, there's a lot of crosstalk, okay? So you can have chest pain in both situations, shortness of breath, palpitations, kind of a sense of impending doom and feeling like something bad's gonna happen. But usually with panic attacks, this usually is self-resolving. It goes away within 20 or 30 minutes. Or if you're in the ER and they give you like something for anxiety, it usually goes away. But it's really hard to kind of tease through this. So I have one patient, she's, I believe, 37. She's gone to the ER probably 4 times this year, thinking she's having a heart attack, only to be told it's anxiety. On the flip side, though, I do think sometimes medical providers often brush off symptoms that women are having and kind of jump to anxiety instead of doing the full workup. So I always recommend, no matter the age, no matter the symptoms, make sure your medical provider is doing the adequate workup to make sure it's not your heart. If it's not your heart and everything looks normal, then we definitely have to have a strong conversation about anxiety as well. But there's a lot of cross-reactivity here, so I think that's important to keep in note as well. Now, in extreme cases, anxiety and stress can definitely cause issues with the heart as well, too. So remember that story I was telling you about? I had so much adrenaline surging through my body, right? That usually happens during periods of anxiety and stress. And normally your body's able to cope with that if it's a transient period or a small amount. When you have a very, very high adrenaline surge, that hormone can actually do damage to your heart and cause a syndrome we call broken heart syndrome. And essentially, adrenaline is almost attacking a portion of your heart, and the bottom chambers of your heart are not squeezing well. So these patients can actually develop a transient or temporary congestive heart failure, and they can present to the ER again with symptoms and signs of chest pain. We usually see this after with patients who are having a very strong emotional reaction. So a lot of the times it's like a death of a family, a traumatic event, a really bad car accident, things like that. And women tend to be more sensitive or more likely to have this as well too. The bad news from this is, again, it can cause very short-term congestive heart failure and heart attack-like symptoms. The good news is it's usually reversible. So again, with medications, people tend to go back to normal with this as well too. Now, another tip is stop smoking. So I don't know if anyone was here last time, but this is one of my big bugaboos that I do in my practice. And my patients, I will straight up nag them. That's the first question I ask certain smokers every single time they see me. Because smoking is one of the most preventable risk factors in regards to cardiovascular death. So about 2.4 million of people are dying every day, and almost 500,000 of those cases are associated with tobacco smoke. So it's very, very important to, if you are a smoker, to try to at least stop. Smoking triples your risk of having heart disease. And even if you're not the one smoking, secondhand smoke also increases your risk. So a lot of times, especially men who are smoking, their wives, they're putting their wives at risk as well too. So 25 to 30% increase of chance of having cardiovascular events as well too. When someone does quit smoking, their risk of cardiovascular events already starts to trend down. So after that first day of you stopping smoking, that risk already starts to decrease. And if you watch these patients after 10 years, the risk actually goes down almost close to someone who hasn't smoked at all. So no matter if you've been smoking for 5 days, 10 years, 30 years, any stopping is going to help quite a bit. Now, I put vaping on here because a lot of people come and ask me if vaping is as bad for you as tobacco. The problem is vaping is very, very, very new. So we don't have a lot of long-term effects of how well it affects the actual heart itself. The good news is it tends to have less toxic chemicals involved with it. The bad news is it has more nicotine, so people usually get hooked on it a little bit more than they would if they were smoking a regular cigarette. What we do know is it's horrible for your lungs. So I don't know if you guys have been seeing in the news lately, especially with President Trump trying to ban this stuff. It is horrible for your lungs. So one of the analogies that I like to think about, so when you're vaping, if you I don't know if anyone's actually seen the tools to vape, but it's actually a liquid that's in there. When you press the button, it vaporizes that liquid, so the patient or the person inhales it. The issue is that once it cools down and is inside your lungs, it likely goes back to a liquid. So think of it like a candle. You buy a candle from the store, it's solid. You light it, what happens? The wax starts to melt. When you blow the candle out, what happens? The wax forms right back. I think that's exactly what's going on with vaping, and it can cause severe, severe pneumonia. We've seen patients actually almost have liquefaction of their lungs from this. And these are young, healthy people like, 20s and 30s going through this. So from a heart standpoint, I really can't give you an answer how it affects your heart, but we know definitely for sure it's bad for your lungs. Now, maintaining a healthy diet. So this is an area that's difficult for everybody. I may not look like it. And I think I mentioned this last time. I like to eat. If you talk to my family, I eat a lot, and I'm a stress eater as well. So keeping a healthy diet is going to help keep your body weight down as well. I think a lot of the times we get kind of caught up in the fad diets like keto and vegan and being vegetarian, but these are kind of just simple tips to kind of help you maintain a healthy diet. Portion size is key. So make sure you're not packing too much on your plate, especially when you're going out to eat. Making sure you're trying to eat more fruits and vegetables, avoiding processed foods and sugars, trying to select whole grains, limiting unhealthy fats, and definitely reducing salt intake. Now, that last one is very, very important for anyone who has established cardiovascular disease. So the more salt you eat, the more fluid your body tends to maintain or try to retain. This can be really lethal for someone who has heart failure, and especially African Americans who have high blood pressure. For some reason, we are more prone to hold on to salt. So the more salt you're eating, that can definitely jack up your blood pressure as well too. So try to keep that in mind. Exercise. So I also hate exercising as well. But it's really important. You definitely want to make sure you're keeping moving. So regular exercise is important, again, for your heart, but also just making sure that your body's working at its optimum. It helps to control all of the risk factors that we've been talking about throughout the lecture. Of course, it doesn't hurt. It helps you lose weight. So if you're trying to get back in shape for the beach season as well, too, that's not a bad thing to do as well. And I always tell patients the current recommendations is to exercise for 30 minutes, 5 to 6 times a week. Honestly, with our lives, everyone's busy. I usually say at least try to do 3 times at minimum. And you don't have to go like try to train for an Ironman or do CrossFit or anything like that. Find something that you like that you can be consistent with and stick with it. So whether it's like riding a bike, swimming, jogging, taking the stairs. So when I'm on call, I don't have time to work out at home. So I take the stairs to go see every patient, even if that's going up to the 24th floor. I mean, I'm out of breath and sweating when I get up there, but I do it because that's my exercise for the day. And walking as well, too. I think a lot of people don't give walking as much credit as it deserves. That's a really good workout. You can just get a couple of miles in, especially if you're going with a partner, listening to music. That's an easy way to work out. A lot of people tend to say, the Houston weather kind of prevents them from getting out. It's really, really hot in the summer. And then like days like today, the weather's all over the place and super cold like 2 days later. I always say even walk indoors. So my parents actually do that. They go to the mall and they walk around. You don't have to shop or anything, but just, go around, walk, and get some steps in. One thing, look, my mom's like, no, I'm shopping. One of the things from an exercise standpoint is every time I talk to patients, they usually ask me like, hey, doc, I walk a lot at work. I walk to the coffee pot. I walk to the copier. I walk to go see my boss. That doesn't really count as exercise. It's good for your steps and can help with your decreasing your calories overall, but it's not really giving your heart that workout that it needs. So in order for it to count as a true cardiac workout, you want to make sure that you're doing some type of activity that's sustaining your heart rate at an elevated pace for at least 20 to 30 minutes. And again, find something, stick with it. That's the key. So that's actually all I have for you guys. Again, thank you so much for inviting me back. There's my contact information on here for anyone who wants to get a hold of me. Happy early Valentine's Day as well, too. And then we can open the floor for questions. Yes, ma'am.
So you explained that men, when they're stressed out, they have a higher blood pressure, and women, they experience a higher pulse. So I understand that when you have a higher blood pressure, it causes damage to your arterial walls. What is the education behind this?
So kind of the same thing. So if you're constantly having an elevated heart rate, almost think about it as if your heart's beating really fast and really hard continuously, your heart's being overstimulated and it's working really hard. So it's almost the same thing. Like if you're at the gym and you're doing arm curls over and over, you're not taking a break, that muscle is going to be sore and weak. The same thing can also happen to your heart. So anyone who's having like palpitations or arrhythmias, that's the risk why that makes that dangerous. Yeah. Yes, ma'am. So when I was in residency, I had a patient pass away from it. The biggest thing is that bottom portion of your heart. Let me go back to this real quick. So when you're looking at the heart, not all of these chambers kind of do the same amount of work. The biggest thing is this left side, your left ventricle. This is what's responsible for doing most of the work of the heart. So this is how you're getting all the oxygen-rich blood to all of your organs. When you have broken heart syndrome, this bottom portion of this left ventricle here, it just completely stops working. So it stops moving. So the pumping function decreases quite a bit. So they're going to have an issue getting blood flow to all of their organs. Their blood pressure drops. And if that lasts for a long time, patients can definitely pass away and die from that. If we catch it early, though, and we put them on the right medications, again, it's almost 100% curable and reversible. Yes, sir.
Dealing with patients that are pediatrics that are going into adult care and everything, when discussing cardiac, how difficult is that when transitioning a patient from like pediatrics and then going to talk about adult heart health?
So in regards to they had congenital or pediatric heart issues and now they're seeing so it depends on the degree of the heart disease or the condition that they have. If it's severe or something that was not fixed that the patient is dealing with, we actually usually recommend them still seeing a pediatric cardiologist at least once a year. There's a new field now because if you go back like to the 80s and such, a lot of these kind of congenital issues, that's when a lot of these corrective surgeries started popping up. So we're just now seeing those first batch of kids where they got corrected now being adults. So there's a whole new realm of cardiology called adult congenital heart care, where now we're seeing those older patients who got fixed before, now we're seeing them. We still don't have a lot of cardiologists that are specially trained for that. So like general cardiologists like me are still kind of assuming care. But if it's something that's very complex, they either have to go to a specialist that's not necessarily in their city or still have to see that pediatric cardiologist at least once a year as well. Yes, ma'am.
So you said panic attack could cause risk for heart attack?
Say that one more time.
You said panic attack could be a risk for heart attack?
Not necessarily a risk of a heart attack, but it can mimic the signs of a heart attack. So usually, if you are having panic attacks, that means there's some underlying stress or anxiety that's not being treated. So we usually recommend them seeing a primary care doctor or a psychiatrist or a psychologist to get some type of psychological care to prevent the panic attacks from even happening. And there's two types of medication that you can be on. There's a medication that helps to stop your panic attack while you're having one. But then there's also like mood stabilizers and medications that help with your overall mood that hopefully help to prevent you from even having panic attacks. So there's definitely options for that as well too. Yeah. I'm sorry. Not necessarily build a heart problem, but again, like she was talking about, when your heart's pumping really fast because of all of that adrenaline and that anxiety, it makes you feel like you're having a heart attack. But if it goes unchecked or untreated, it can cause weakness of the heart long term. But in that short term period, usually it doesn't cause any issues. So blood pressure usually tends to go up as well too during the panic attack as well. That can definitely cause it. So I saw a patient actually a couple of weeks ago. Her blood pressure would always go up at night. And we can actually send patients home with a blood pressure machine that you actually wear for a full 24-hour period. And she was right. Every time, like around 10 p.m., her blood pressure would spike up. And so for me, being a cardiologist, I just kept on giving her more medication. And then we repeated it and still the same thing. So finally I brought her in. I was like, what's going on around like 9 or 10? And she's like, oh, my husband comes home at that time. And it was him who was calling her. Yeah. So that can definitely cause it as well too. But again, treating the underlying issue is what you need to do there. Sorry, I know I'm picking on the guys today. Say that one more time. Mm-hmm. Mm-hmm. So coffee usually increases your heart rate. It doesn't necessarily increase your blood pressure. It's mainly heart rate that we see. And I'll talk to you offline as well too. There's other different things. If it's purely in the morning, there's some other things we have to discuss. But hang around after, and I'll tell you about that as well. Yeah. Yes, sir. Say that one more time. Pre-workout supplements. Oh, you asked my wife. I had to get off of that. So most younger guys I see, so with women, most of the younger women I see with palpitations, it's from anxiety. But for men, it's pre-workout supplements and caffeine abuse. So I had one guy, he didn't really realize, if you look at the pre-workout supplements, there's a lot of caffeine. And some of the higher concentrations can have the equivalent of having 8 cups of coffee in one scoop. So you can imagine if you drink 8 cups of coffee in a couple of seconds, and then on top of that, you're going to work out too, that can definitely cause your heart rate to go up. So I always tell people, we usually recommend not to be on it, but if you are going to do it, you definitely need to do it with caution for sure. And I wouldn't do any other caffeine outside of that as well. So sodas, all that stuff, I would wipe that out. But yeah, I was on it, and I mean, I think I took it, and I didn't realize how long it lasts. I was at work literally just like shaking and sweating. So yeah, just be careful with pre-workout for sure. Yes, sir. That's an excellent question. So usually we don't necessarily recommend people to see a cardiologist just, for regular evaluation, but that's actually a pretty good instance. Someone who has heart attacks in their family, especially at an early age, you want to start getting checked, your blood pressure, cholesterol, diabetes, all those risk factors that we were talking about that we can change. we really need to be aggressive in pinpointing those. Of course, you can't change your family history, so there's still going to be a risk of you having that. But the things that we can control, that's what we have to kind of focus. And then you definitely have to make sure you're going to the doctor regularly so that if you do start developing any symptoms or signs, we can catch it early. Yes, ma'am.
Does it make a difference during transplant, having, like, let's say, I'm a female, do I have female donor?
No, not that's a really good question. So I'm not a heart failure specialist, but I can still answer that. So it's not necessarily female to male or male to female. It's usually body size. So if we look, how tall are you? So you're 5'7", so I'm 6'2". So I probably can't get someone's heart that's your size because it's not going to be enough to supply my stature, and vice versa. My heart may not necessarily even fit in your chest cavity. So it's mainly about body size is the thing. You want to make sure those match, not necessarily gender.
Female heart is more than female.
Well, the average female and the average male, but of course there are, like, let's say like men who might be your size or even shorter. Their hearts might be closer to your size more than like someone like me who's taller and bigger as well. So it's mainly about the size. That's the biggest thing. That's a really good question. Oh, I'm sorry. And the other thing too is people get confused in regards to like size as in their weight, and that's not true either. So someone who's my height and size, we're mainly talking about our ideal body size. So what our true weight should be, and not because if you're obese and you're 6'2", he still probably needs a heart that's my size. So that doesn't change just because he's bigger than me as well. That's important in factor. That's a really good question. Yes, ma'am.
Can you talk a little bit about AFib?
Yes, ma'am. So AFib, I'm glad we kept this picture up. So AFib, remember we were talking about these chambers. So the bottom chambers, again, these are called your ventricles. And the top chambers here, these are your atria. So with atrial fibrillation, usually it's this top left chamber here. Instead of squeezing and delivering blood, it starts to quiver. The other thing is the way the heart talks to each other is usually through these electrical impulses. So think of it almost like a power line system. So there's a power line system that works in the heart, and it actually synchronizes when these chambers are supposed to beat. With AFib, people usually have like a lone power line here that's working on its own, and so it's almost working on its own loop, and it's surpassing the true kind of power line system. So it beats really fast, and it sends signals to the bottom chambers of the heart to beat fast as well too. So usually people end up having heart rates really, really elevated, so above 100. It can make you have symptoms of palpitations or feeling like you're going to pass out. Because the chamber is not squeezing and delivering blood, it's more so quivering. Blood clots can form in that chamber. And if you have a blood clot in this chamber, if it comes down here, then out to your aorta, it can go to the brain and cause a stroke. So there's a risk score that we calculate as well too, and that tells us if you need to be on a blood thinner to prevent that as well too. Women are at a higher risk for atrial fibrillation. For some reason as well too, athletes who do like long distance running or endurance sports tend to be at a higher risk as well too. And we think that's because this chamber here gets dilated with those sports. So it causes irritation of that power line system, and it predisposes them to have atrial fibrillation. There's a lot of different treatment options. You can have medications, but anytime I have a younger patient or a patient who's never had AFib before, we can actually send you for a procedure that actually burns an area of your heart muscle, and it stops that abnormal loop from working on each other, and it can cure you of AFib as well too. That's a good question. Yes, sir.
What we should do is that you have a patient who has a heart disease, but also how you minimize that level of anxiety.
So that's a good. So you mean having concomitant anxiety and having heart issues? The biggest thing is, and I always tell patients this, even if you know you have anxiety, if you have severe chest pain, you have to be evaluated. So whether that's going to the ER or going to your doctor, because the biggest thing is you want to make sure it's not your heart first. Once we know it's not your heart, then we can deal with the anxiety after. But always, it's really important because we definitely don't want to miss someone actively having a heart attack. You need to have that evaluation, that cardiac evaluation first, and then we deal with the rest if all that's negative. Yes, ma'am. Not really. So in some people, it's pretty good, but I mean, like, so I wear a Fitbit and my heart rate, it never really correlates well. So going back to that same patient that we were talking about with the blood pressure monitor, we were getting such different readings from her Apple Watch in comparison to what we were checking her blood pressure. So they don't always correlate. I think one good thing that it sometimes does, it tells you like the trends. So whether your heart rate's going up around a certain time, and sometimes it'll tell you whether it's irregular or regular. I think it's really good for that, but they're not necessarily always completely accurate either. Yes, sir. Okay. As in like from a physical activity standpoint? So that's a little harder for us to assess. And two, especially if they're not having symptoms. In certain cases, like how you were saying, like patients who are having like a strong family history of having cardiac events or certain cardiac risk factors, if we can't rely on their physical activity to show us that they're having symptoms, doing like prophylactic stress tests aren't a bad idea in those patients to hopefully see if we can pick if they're having any underlying blockages early as well too. That's a really good question. Yes, sir.
This can a moderate amount of alcohol consumption lessen the risk of cardiovascular disease?
Lessen or increase? Lessen. So let's talk about both. So, and this, I feel like women always get the short end of the stick when it comes to alcohol, but what we consider binge drinking, so men doing more than two different drinks in one sitting, and women is actually more than one, which to me makes no sense. It's considered binge drinking. If you are drinking a lot, your heart can actually respond poorly to that. And there's a different type of heart failure called alcohol-induced heart failure. So too much alcohol can actually cause you to have heart failure as well. In regards to the benefits, just like blood pressure, there's a different article about the effects of alcohol, whether it's good or bad for you, literally like every week. So when I first started med school, they were like, oh, red wine is the best thing for you. It helps. And then I was in residency and they said, oh, red wine actually is bad for you. And now we're kind of on the upswing where they're saying red wine is good. Honestly, these studies go back and forth. As long as you're not drinking too much, usually it really doesn't matter too much. But I wouldn't rely on alcohol for your cardiac benefits, though. Yeah. Yes, ma'am.
How do you know whether you're having panic attack versus heart attack instead of saying
So you said besides going to the ear? So that's the problem. In order for us to know that you're having a heart attack, we do this thing called an EKG, where they put these stickers and these leads on your heart, and it shows us the electrical activity. And there's certain patterns that we see that tells us whether you're actively having a heart attack. So that's one way. The other way is there's a number called troponin. It's almost like a help signal. So if you're having if you're having a cardiac event or cardiac muscle death, that number is usually elevated in your bloodstream. So that's the two major ways that we can figure out whether you're having it or not. Outside of doing that, like outside of a clinic and stuff, it's really hard, but those are the two major things that helps you figure that out. And it's usually what we call, we rule you out for an acute heart attack. That's what that's called. Yeah. Yes, ma'am.
So what is most likely to happen to a person that vapes and smokes at the same time?
So for sure, smoking, their risk of cardiac events is going to go up. And then vaping, again, it's that respiratory effects that we get really, really worried about. Oh, 100%. I really feel like eventually they're going to prove that vaping is probably not good for you either. There's just so much we don't know about. One of the things that kind of scares me is, so a friend of mine was vaping and I had no idea because it's odorless. So we know for sure secondhand cigarette smoke is bad for you. We have no idea what the secondhand vaping does. And because it's odorless, a lot of people do it indoors. So we're next to kids or next to adults, and we have no idea what that secondhand vaping does either. So only time is going to tell. We're just going to have to do studies and figure out how it affects us. But of course, we always recommend not doing it. I think as a medical community, we're a little disappointed because when it first came out, it was kind of promoted as a way to stop people from smoking. So we all got excited that that's a way we can stop you from smoking. But now we're figuring out that's not really good for you either. And on top of that, again, that nicotine content is really high. So there's actually increased chances that you'll get hooked on the vaping. And in certain cases, the vaping is actually a gateway for people to start smoking cigarettes. So overall, it's just not that good of a thing to do. Yes, sir. So with people with heart disease, it's mainly your fat intake is the number one thing. So not doing a lot of fried foods, trying to do lean meat. So not a lot of red meat or pork, trying to stick to like your chicken. And then one thing that I had to learn is like with fish, I would eat fish all the time and thinking I was being healthy. But even with fishes, like things like tilapia and catfish are actually very, very fatty. So you really want to go more towards salmon and the white fish and cod and stuff like that. But trying to decrease the amount of fat intake is a big one on that. So pork is super fatty and it's super salty. So it's not the best thing. It's good, but it's not good for you. Yeah. Yes, ma'am.
How accurate or accurate is taking like a baby aspirin
Mm-hmm.
to prevent a heart attack as a right? How true is that?
That's a good question. Not just because she's my sister, but that's a really good question. So I don't know if y'all have noticed recently, they've been talking about that in the news recently that they don't know how well aspirin is preventing heart attacks. And what kind of worries us is a lot of patients came in just stopping their aspirin willy-nilly. So first of all, if you're on aspirin or your doctor told you to stay on aspirin, do not stop it without talking to them first. What that kind of study shows is the people who are lower risk, so women who have no risk factors at all, men who have no risk factors at all, taking an aspirin may not give them the same amount of a benefit as someone who has a higher risk of heart disease. But the biggest thing when it comes to aspirin is that picture that we saw before. So it's that picture right here. So remember I was saying, when you have the heart attack, you have this area of plaque, and this disrupts, and then you form a clot. If you're on aspirin, you're less likely to form that clot. So that's what protects you from having a heart attack. Again, yeah. No, you good?
Do you wait for someone that may have their family history of heart disease or someone in their family has had a heart attack? Is it wise for you to go ahead and just take the initiative to maybe add that baby aspirin to your vitamins, every once in a while, or do you recommend absolutely seeing a doctor and having the doctor put you on that baby aspirin?
So I always say talk to your doctor first so that one, things are documented. You guys can talk about the benefits and the risks because it really depends on the patient. But remember that 10-year risk score we were talking about before, that actually helps us too. So if you score pretty high on that 10-year risk score, that gives me more evidence that you might benefit from taking that aspirin versus someone who's at more lower risk. The other thing, if you are doing aspirin, make sure you're doing the 81 and not the 325. We really haven't seen an increased benefit in taking the full aspirin versus the baby aspirin. And that 325 increases the risk of you having an ulcer and gastric and stomach upset as well too. But I'll definitely talk to your doctor and make sure you're checking that risk score as well. Yes, sir. So when it comes to herbs and stuff, and I'm someone, I believe in both, especially if someone comes and shows me evidence. The problem is there's not a lot of studies with herbs. So if you think about it, like medications and stuff like this, these drug companies spend a lot of money to prove that their drug works because there's money in it. There's not a lot of money in herbs, so we don't have a lot of good evidence for that. So one of the most popular things is like the apple cider vinegar or garlic. I think some of that stuff might help. We just don't have a lot of foolproof evidence to tell you how much it helps. In regards to cholesterol, there have been some studies on some natural supplements. There's one called red rice yeast. I don't know why I can never say that. Red rice yeast. That helps to decrease your cholesterol. And then like things like fish oil, omega oils, and as well too, those help as well too. But the problem is we just don't have a lot of good evidence on a lot of that stuff. And that's what makes it tricky for us to be able to recommend it. Yeah. Yes, ma'am.
In regards to patient-provider communication, what do you find the hardest to do, I guess? Like, for example, or what do you find the patients that they tend to do? For example, do they tend to keep from the patients what foods they've been eating in regards to heart disease and stuff like that?
That's a good. Is she in the class? Yeah, give her extra credit. That's a good question. So that's a big passion of mine, and mainly because before I was a doctor, I was a patient as well too, and I would always feel like the doctors would more so talk at you and not talk with you, and that's something that I take really seriously when I see patients. So I think one of the major things that I've noticed or that I see is the lack of transparency. So a lot of the times I think doctors either they talk about the scientific stuff and don't necessarily break it down to a level that people can understand it, or they're really, really brief and they're really, really quick and they don't make sure the patient understands what's going on. So, I mean, I've had multiple patients, I keep on having all these stories, but in medical school, I saw this one lady, she had scars just all over her stomach, all over her chest. And I was like, where is all this from? And she's like, oh, I had all these surgeries. I'm like, okay, what did they do? And she's like, I don't know. The doctor told me I needed to take it out, so they took it out. So there's a lot of times patients will come in and they don't really know or understand what's going on in their health. And I think that's really important, because if you don't have skin in the game, if you're not dedicated to knowing what's going on, then why would you expect that patient to be motivated and want to actually get better? So I think it's the communication and the patient relationship with the physician. So even if it takes that extra mile, you got to make sure that the patient understands what's going on, because I think that's a key to making sure they're going to get better. But that's the number one thing for sure, is communication. Yeah. Yes.
So, as a care provider, what advice would you give to someone who's like a self-advocate, who knows that there's something wrong,
Mm-hmm.
and they're trying to communicate with their doctor, and they're not, they're not being heard?
So I think that's important. One is to always be an advocate for yourself. I've had issues with that as well too, where I feel like the provider or the doctor I was seeing is not necessarily getting what I'm trying to communicate. The first thing is, and I'm not trying to plug Kelsey, but this is, a little sly. But the thing about Kelsey is we have on our website, all of our providers are listed, and you can actually watch like their bios and a small interview with them to kind of figure out what type of doctor they are. I think that is huge. And I wish I had that when I, first started getting care of myself, because I think that goes a long way as well too. Getting someone that gels with your personality, that has the bedside manner that you fit with. So I'm somebody, I'll sit there and talk to a patient all day if I have time. And sometimes, we'll talk about stuff that's not related to their health. We'll talk about Jersey Shore and everything. But there's some patients, they don't like that. They want you to be hard on them and tell them exactly what they need to do. They don't want all that, all that extra stuff. I think that's the biggest thing, is you just got to find a provider that gels well with your personality and that meets your criteria. If you're not getting that, there are way too many doctors available. Find somebody else.
So, what if it's in an emergency situation?
Oh, then you just keep on advocating for yourself. And usually in medicine, there is a chain of command. So I don't know, my wife's here. I hope she don't mind if I share this story. So we've had issues where, when our daughter was going to be delivered, I felt like they weren't telling us. And mind you, I'm a whole cardiologist. I'm a doctor. And they still, I felt like, weren't really communicating with us at times. And you just have to keep on being persistent. If the nursing staff or whoever's there, if they're not listening to you, who's above them? The nursing manager. If the nursing manager is not listening to you, who's above that? Go to the physician. So go up that chain of command and make sure somebody listens to you. The good news is I think there is a cultural shift that's going on now. Before, especially in these older doctors, they definitely were like, you do what I say, and if you don't like it, you leave. But I think now patients are taking that power back, and now it's more of a partnership. So just keep on going up the chain of command until somebody listens. And trust me, if you make enough attention, especially like if really nobody's go to the news, I'll guarantee you they're going to change some stuff with that. So just keep on escalating the chain of command for sure. Yes, ma'am. To be 100% honest with you, I feel like a lot of physicians weren't even kept in the loop with that. A lot of the times it was the patients coming up to us saying, hey, I got a call from my pharmacy saying that this is a bad batch of medication. What do you want to do? Or I had this one lady, she had like 3 letters that she got from every single medication that she was on. I can't speak to their efficacy, but I think in situations like that, the power again lies in the consumer and the patient, and we have to just make sure that we're continuing to make as much noise as possible and keeping those who are in positions of power accountable. That's the only way I think that things are going to continue to get better and change. But I'm sorry. Yeah, what's up? I think it's a little too early for that. I think a lot of these things are probably, especially when it comes to cancer, it's usually exposure is the name of the game. So exposure and longevity, that might be something that's going to happen later on down the road. But right now, I haven't seen any of that. I've had a couple of patients actually write letters to the FDA and the makers of that medication. I think that's a good way to start. And then make sure in your history that you also note that. So God forbid, but if you do have something happen in the future, you can recall back like, hey, I was affected by this medication in 2019. What are we going to do about it? So again, being an advocate for yourself. Yes, ma'am.
Can we go back to postmenopausal women and the estrogen?
Yes, ma'am.
Do you recommend estrogen replacement therapy?
So, yeah, they're completely split on that. And so I have some close friends who are OB-GYNs, and even they don't really know what the best answer for that is. They're working on newer versions of the older supplementations, and I think that's going to maybe make a breakthrough. But right now, there's no real big hardcore consensus because it's like one thing gives you the benefit, but then the other thing gives you the risk. So it's really hard to figure out with that. And even our OB-GYN colleagues, I feel like are torn on that as well too. Yeah. Yes, ma'am.
Going back to like patient communication.
Mm-hmm.
Have you ever like dealt with a patient like you saying that you want to find with them and you're just doing 100% and they still doubt what your diagnosis is?
Oh, all the time.
Yeah, but it's like, do you feel at that point that you're comfortable to give them other doctors?
So
Like, just to have them feel out the fear and come back to you.
100%. So I mean, again, I can talk to a brick wall. So I will do my part. If they don't feel comfortable, or especially if they don't feel like they're getting what they need, I always be like, you know what? Hey, one of my friends specialize in this. If you want, go get a second opinion. If you ever need me, I'm still here. But at that point, it's up to the patient. But I 100%, if they feel comfortable or feel like they would do better with someone else, I'll definitely recommend that. Yeah. Yes, ma'am.
What will you do if, let's say, the patient will take some medication or something, and he comes back with the same, you do a test and you kind of review that he was not taking that medication? How would you look if he's saying that he took the medication, but the test results are showing different?
Oh yeah, I got to make one of those calls later today. That happens all the time, especially with cholesterol, because those something that we can measure. So if your cholesterol was 250 when I first started the medication and it's 251, either you're not taking the medication or something else is going on. Again, it just comes back to making sure the patient understands why they're taking it. And for me to understand why they didn't take it as well too. Sometimes, a lot of times, especially these medications you take at night, people just forget. I mean, I'm horrible with taking with medication, so I can't expect patients to do something that I'm bad myself. So it's just making sure that we're keeping that line of communication open, make sure they understand my expectations, and they understand exactly why I'm prescribing it as well. Yeah. Yes, ma'am. Mhm. Like, how do we pick which medications? For sure. So the rule of thumb usually is if you are coming into our office, well, first off, we don't diagnose anyone with high blood pressure unless you've had 2 readings above 140/90. So like a lot of people come into the doctor's office and they're nervous. They have like white coat hypertension. So when they come in with an elevated reading, I usually have them monitor their blood pressure at home. If they're still having elevated readings or it's elevated that second time, then I give them the diagnosis of high blood pressure. If you have a blood pressure of 160 and above, ideally you need to start no matter what on 2 medications. It's going to take at least 2 to really bring you back to 120. There's different ethnic disparities as well too. So like African Americans, we don't do well with a medication called ACE inhibitors. We tend to get a cough and get swelling of our lips and stuff. So I usually don't give that for African Americans. If there's somebody who like has swelling and they have an elevated blood pressure, I usually give them diuretics. If they have a fast heart rate and high blood pressure, there's a medication that works with that. So I usually try to, approach it that way. And then my biggest thing is I want to put them on the least amount of medication possible. So if there's anything that's going to give us the biggest bang for our buck or kill 2 birds with 1 stone, that's usually the direction I start in. Yeah. Yes, ma'am.
Have you ever dealt with any cultural barriers?
Say that one more time.
Have you ever dealt with like cultural barriers with trying to communicate with your
Oh yeah. So I can understand some words in Spanish, but people will try to like butcher their way, do like a Spanish exam, and I'm like, especially if the patient doesn't feel comfortable. So I always try to get like translators and things like that. one of the most common things is sometimes, patients who are Jehovah's Witnesses who don't accept blood products. Cardiologists always get nervous in those situations. Again, you have to just sit down and talk to the patient, understand what they want, and go from there. Even though we're, from different cultures, everyone has the same type of, goal. They want to feel well, they want to stay alive, they want to be there for their families. If you can kind of vibe with them with that foundation, the rest is usually pretty easy. Yeah. Yeah. I don't know who's first. I think you were.
Well, so I just went to my previous class and there was a question regarding like a child that was in a car accident coming from a Jehovah's Witness family and he needed a blood transfusion. And we were kind of told to identify that Adesina and all of that. Is that something that you see often that happens?
Oh, yeah. Oh, yeah.
I'm sorry. And does the child separate from the parent on your point of view? Like, that's what I think. I feel like the child has his own say in his life or not.
This is a minor, though, correct?
Yeah, it's a minor.
So that's what makes it difficult, because with those minors, it's whatever the parents want, because they're just not old enough to make their own decisions. We do say that a lot, especially patients who've had a stent placed in their heart. To keep that stent open, they usually need to be on a blood thinner. So like patients who have been having issues with like bleeding and stuff like that, that usually comes up. Or patients who have like, they're going for like bypass surgery in their heart, that also comes up in our pre-op questionnaire. Again, make sure they understand the risk and make sure you understand what they expect. But you definitely can't force anything upon a patient. Yeah, if it's against their will. And then, yes, and then if you feel uncomfortable, always getting like a social worker or an ethics officer to help you guide you in that decision making also is helpful as well too, for you and for the family. Yeah. Okay. All right. If that's everything, thank you again for having me. I'll hang back if anybody has any more questions or if you're too shy to ask or anything. Thank you so much.